This slide summarizes the relationship between ischemia, vasoconstriction, volume overload, and inflammation. There is a progressive physiological cycle. If a myocardial infarction is secondary to a cardiac injury, there is a reduction in cardiac output, and as a consequence, a decrease in organ perfusion, an increase in volume overload, and multi-organ dysfunction. In addition, there is an increase in vasoconstriction, microcirculatory dysfunction, and sympathetic stimulation. This produces an increase in ischemia and inflammation, and this closes completely the cycle. The situation is present with different degrees in patients with heart failure, but cardiogenic shock is the end stage of several patients with heart failure. Next, please. This slide summarizes the points that we will try analyze in the next 9 minutes. Prognosis in this particular situation. There is not a lot of evidence about this particular scenario. After the management, the predictors of risk of evolution, and finally the challenge in the next future. Next. In relation to the prognosis in this situation, next. This slide shows the impact of prognosis of the presence of heart failure and left ventricular ejection fraction in patients with acute coronary syndrome. On the left side, you can see patients without heart failure during the hospitalization. You can see that in this particular situation, the left ventricular ejection fraction has a prognostic value, and patients with reduced ejection fraction show a more important reduction in survival. On the right side, you can see that patients who present heart failure during the hospitalization for acute coronary syndrome. You can see that in general, the survival is reduced in comparison to patients without, and the ejection fraction don't have any predictive value, and you can see that the evolution is independent of the ejection fraction in the baseline situation. Next, please. This slide shows the relation between high sensitivity cardiac troponin and the risk of heart failure in acute coronary syndrome during the hospitalization. You can see that the increase in troponin level is associated with an increase in heart ratio to present heart failure during hospitalization or death. There is an association between the peak of troponin, of cardiac troponin levels, and heart failure hospitalization. Cardiac troponin is a marker of heart failure in patients with acute coronary syndrome. Next, please. In relation to the management, next. This slide shows the impact of in-hospital revascularization on survival in patients with non-ST elevation, acute coronary syndromes, and heart failure. You can see that the death rate at 6 months is significantly decreased in patients who underwent percutaneous or surgical revascularization. On the other hand, patients without revascularization show an increase in mortality. You can see that the curves start the separation just between the second and the third month after the index event. Next. What about the time of revascularization for patients with heart failure with acute coronary syndromes? This slide summarizes the recommendation of the recent guidelines, European guidelines, and recommend that an immediate invasive strategy in the first 2 hours is recommended in patients with heart failure clearly related to non-ST elevation acute coronary syndrome. Next. The following question is what strategy or vascularization we need to do in this patient. There is important variability in relation to, or recommendations in relation to, the severity of heart failure. This slide is from the Groupe ACTION trial, where patients with multivessel disease with acute myocardial infarction and cardiogenic shock were randomized to PCI only in the Kuppler lesion or PCI in all the rest of territories with immediate multivessel PCI. You can see on the right side that the mortality at 1 month And the mortality at 1 year was significantly at 1 month, a tendency 1 year increased in patients where multivessel PCI was applied in comparison to patients randomized to the treatment only in the culprit lesion. Next, please. The situation is different when the complete revascularization is evaluated in patients with STEMI and multivessel disease. This is a meta-analysis of different randomized trials, and you can see that on the left side in relation to associated to myocardial infarction, cardiovascular death, or repeat revascularization, that the evolution is favorable in this particular meta-analysis in patients where complete revascularization in comparison to patients where only culprit lesion was treated. This is, this conclusion is evaluated or associated with myocardial infarction, with cardiovascular death, or repeat revascularization. One important point to note is in this particular meta-analysis, only between 5 and 11% of the patients included show a Killip class between 2 and 4. Next, please. The situation is very similar when multivessel in comparison to culprit revascularization has been evaluated in patients with non-ST elevation acute coronary syndrome. This is a systematic review meta-analysis, and you can see that in the evaluation of shorter evolution, there is not impact of the type of revascularization performed. The evolution is similar if patients were randomized to multivessel in comparison to patients treated with only culprit lesion revascularization. But in the long-term follow-up, you can see that the incidence of MACE, MI, all-cause death or repeat revascularization was significantly reduced, favorable to multivessel revascularization in comparison to only culprit vessel revascularization. Next, please. What are the predictors of evolution in this particular scenario? This slide and the following slide will show the clinical and anatomical criteria to identify high-risk PCI. PCI is performed in the majority of patients with STEMI and more than 60% in patients with non-STEMI, non-ST elevation acute coronary syndromes. These criteria are associated with the appearance of heart failure or with a deterioration of heart failure. Clinical criteria associated with an increase in heart failure, ejection fraction lower than 30%, hemodynamic instability, the presence of refractory acute coronary syndrome, mechanical complications, and advanced age, the presence of comorbidities, and an advanced Killip class. Next, please. The anatomical criteria associated with an increase in the presence of the risk of heart failure in patients with acute coronary syndromes are the treatment of an unprotected left main, when the intervention is performed in the distal left main bifurcation, multivessel disease, the revascularization of a degenerated CABG, when the last remaining coronary vessel is treated, when there is an important amount of the myocardial at risk, or when the multivessel disease is extended, or when the target vessel treated, providing a collateral supply to an occluded segment vessel with an important amount of the left ventricular myocardium at risk. Next, please. What are the challenges in the next future? This slide shows different mechanical circulatory support device to give support to the left ventricle and percutaneous coronary intervention, intra-aortic balloon pump, impella, tandem heart, or ECMO. However, the evidence about the benefit of these different circulatory support device in the acute coronary syndromes is very limited. Next, please. However, from the rational point of view, the potential physiological impact of these devices in theory is very favorable. This is one study where the hemodynamics was evaluated during Impella in high-risk patients with reduced ejection fraction treated by percutaneous coronary intervention. You can see that at the time of during PCI, when the Impella worked, the pressure was systematically maintained to a level to maintain or to to preserve the vital organ perfusion. In theory, the hemodynamic impact of this device is very favorable to maintain a correct hemodynamic situation. Next. This is the last slide. This slide shows the ongoing trials in cardiogenic shock, or in cardiogenic shock, investigating percutaneous mechanical circulatory support. Probably we will have the final result of these trials in the next 2 or 3 years. The trials are designed to cardiogenic shock, but probably we will have additional information about the potential role of these devices in advanced heart failure. One important point to note is that between these 10 trials, only 2 trials are performed or designed with Impella, and 7 of the 10 are designed with ECMO. I think that probably in the next future, we will have additional information that at the present time we don't have this important evidence about these different devices. Next, please. Thank you very much for your attention.
Angel, thank you very much for this beautiful overview, and we have clearly a couple of questions to answer, but let's start with the presentation by Sergio on bleeding. And please, Sergio, tell us what is the best way to evaluate the bleeding risk of the patients. Do you use scores, and which one? If you don't use scores, how do you evaluate the risk of bleeding? Because when we perform this survey again before the meeting, we have 55% of the audience saying that they don't know really how to treat these patients at high bleeding risk. So we need to tell them first how to identify these patients. So what do you do in your practice? And second, we understood from you that, of course, there is all these strategies of de-escalation. But first, tell us how to evaluate the bleeding risk.
I think, thank you very much for the question. I think that the ARC criteria are the most complete way to evaluate now the bleeding risk. The risk scores are well, but the discrimination is low. It's not a very high discrimination. It's not similar to Grace score, for example. It's also for the Crusade, for the Precise. So the ARC criteria, I think that are more complete and are also good for the in-hospital phase and also for after discharge. So I think that they are important. And also for the bleeding risk, it's important to consider that it's a dynamic risk. So we have to evaluate not only in one point at the discharge or at admission. We have to evaluate on several moments, and when we decide to continue or stop dual antiplateral therapy, we have to evaluate in this moment the bleeding risk. And in my opinion, I think that ARC criteria are good. I think that we need maybe more validation of this criteria. Now we have a study in the European Heart Journal from the group of Zurich. So this is important, but we need more evidence. And in this patient, in our sample, the patient is high bleeding risk for the age of the patient that is higher than 75 years old, and also for the hemoglobin, is hemoglobin 12.9, that is a man, so it's anemia, and there are 2 minor criteria, so this is considered a high bleeding risk because it's 2 minor criteria of high bleeding risk according to the ARC. And I think that the best strategy in this patient is dual antiplatelal therapy with clopidogrel. I think for me, in my opinion, at least 6 months, and at 6 months, you have to reevaluate, reassess the bleeding risk, and if the patient has not anemia, not bleeding in the first 6 months, I continue with clopidogrel for other 6 months. But for guidelines, it's only 6 months of dual antiplatelal therapy with clopidogrel.
Okay, thank you, Sergio. Jean-Philippe, what are the major criteria for high bleeding risk? What would you select?
Well, in this practical example of Sergio, there is no, I would say, major, high bleeding risk criteria. But he's probably, the patient is borderline in terms of age, but age is not a major criteria. He's borderline also in terms of renal function, but he has no other frailty index or severe anemia or prior strokes or bleeding diathesis, which may lead to a immediate high bleeding risk. But I think that the example of Sergio is very good because the patient is borderline and the patient would have been eligible for the twilight strategy. So, we may fear, an immediate risk of recurrent ischemia because, of the vessel disease and the clinical presentation and the PCI. So he may have been a good patient to be put on ticagrelor and aspirin, and then after 3 months, if everything is okay, it could have de-escalated, to ticagrelor alone or any other kind of, de-escalation strategy, and then have a safe follow-up, I would say.
Yes, but when we say age, 75 is not like 85. And I think there's a gradient of risk among the elderly. We don't see that really in all these scores that we have.
Yes, I agree, and I think ARC-HBR is a good score for PCI because usually, PCI is mainly performed for ACS at an average age of 70, 75, but then the calibration of this score, for example, for the patients who are undergoing TAVR is very poor because you have all these high bleeding factors and the discrimination is very poor.
Yes, Sergio, you showed that GI bleeding is quite frequent. It comes second after bleeding at the puncture site, but you didn't tell us what we shall do with PPIs. Shall we be systematic in using PPIs? Shall we use PPIs long-term? Shall we use PPIs for life? There are also side effects of PPIs on the long term. So tell us what is your advice?
Yeah. I think that for patients at high bleeding risk, PPIs are mandatory, at least for the time that the patient is with dual antiplatelal therapy. And maybe I think that if the patient is with antithrombotic therapy, only single antiplatelal therapy, I think that is recommendable to treat with PPI because the risk of bleeding is high. If the risk of bleeding is not high in these patients, maybe you have the question to not treat, but with high bleeding risk, I think that they should be mandatory.
Okay, thank you, Sergio. We're going to move on to heart failure a little bit. Ángel, you showed us very clearly that it's beneficial to have multivessel revascularization in STEMI patients. You showed us that it's probably beneficial to have multivessel revascularization when you have ACS and heart failure. But we have the culprit shock study. How do you explain this different outcome in culprit shock? Is it because multivessel PCI was performed in the same setting? Or is it because shock is so different from heart failure that you cannot generalize what we think about heart failure to shock?
It's a very difficult question because all the people speak about this explanation. I think that that cardiogenic shock is not an homogeneous entity. It's not the same cardiogenic shock secondary to a patient that at the street has a cardiac arrest. The maneuvers last perhaps 15 minutes. Is different in comparison, for example, a patient that the cardiogenic shock is developed during the hospitalization because there is a progressive lack of response or progressive refractarity to the treatment, and the cardiogenic shock is slowly established. It's completely different because, for example, in the culprit or even in the shock trial, one important amount of or even the trials performed with small trials performed with devices in the shock situation, one important percentage of the patients are patients after cardiac arrest. In these patients, the redistributive scenario, the hemodynamic is different to have a response, for example, on the several devices. And in addition, you know very well that the PCI in patients where the shock is very deep after 15 hours of evolution, the treatment, the response to open the artery is very bad. The thrombosis is very often, even to treat in this situation with a very bad hemodynamic situation, to treat the rest of the lesions, to treat a complete revascularization, probably the final result is bad. The question is to select the patient in a very particular situation to achieve the potential benefit of the revascularization or of the devices, because from the physiological, from the hemodynamic point of view, there is enough evidence that this approach gives benefit on the prognosis.
Yes, thank you, Angel. One more question. You showed us an impressive list of studies which are about to start or have started concerning cardiac assist devices in shock patients. It's going to take years to get a response to the question, is it useful to have ECMO or to have impeller in these patients? While waiting for the results of these patients, what is your advice? Because this is the next frontier in acute MI. To reduce mortality, we will need to have an impact on shock patients. So what is your advice for the few years while waiting for the results of the randomized studies? Do you advise us to use ECMO, or do you advise us to be conservative?
Depending on the patient, probably. In my opinion, perhaps is, for example, if a patient were with cardiogenic shock in the first 3 hours or 6 hours of acute myocardial infarction, when there is still viable myocardium, probably ECMO, you know very well that the ECMO establishes an important afterload, and probably it's very difficult to maintain the perfusion or to maintain the viable myocardium in this situation. I think it depends of the profile the patient included in the different trials. And one potential benefit in some patients, mainly in the first period of the acute myocardial infarction, is the combination of ECMO plus impeller, because give a different support from a more complete hemodynamic from the physiological point of view support. But I don't have the answer, another prediction of the results of the trials.
Yeah, it's a good point that you make, combining ECMO with impeller, or at least with a balloon pump. You can reduce the pulmonary edema in these patients, but we still see that it's not something which is available everywhere.